Are you unsure why you failed SCA? Maybe you've given it your best, you sacrificed your weekends and nights. When the results came through, you miss it by a few marks. What if you could identify this blind spot and change your approach so that next time you sit your exam, you pass it? In this video, I'm going to show you what are the common pitfalls to avoid so that you don't fall into these common traps.
First thing that we're going to go over is the five horsemen of the consultations. So there are five saboteurs in a consultation that are lurking, and in any consultation you might find it. And these are things that you have to be looking out for. It's very predictable and it could derail your consultation. So the first one is a scattergun. So this is where you might feel like you're in the middle of a consultation and the patient say to you, yeah, I drink alcohol. And you ask them, how many do you drink? They might tell you, I drink 6 cans of beer a day. So then what happens is you get into the management, you start to give them advice and do the management because you're tempted to do that then. Then when you get to the management, you realize you didn't ask something about their mood. So then you ask question and go back in data gathering. So when this happens, you have a disjointed consultation and it's very disorganized and it looks like you're taking a haphazard history. You might be missing something. If you try and do a bit of management and a bit of data gathering, and then what you'll find is that it's very chaotic and you might miss something, you might not know what you're doing. Keep the structure in the back of your mind. Know what you need to do with respect to time. So for example, get the story and the three buckets: eyes, medical, and the psychosocial. The dictator is rarely focused on what they want to do. So maybe it's a doctor's agenda. They will be asking various questions. They don't really address the patient's eyes. And also they decide for their patient. And the problem with that approach is that you're too doctor-centered and you're going to exclude the patient in the decision making. Okay. And what you need to do is you have to be thinking about the person and what would be the best way of interacting with that person, not as a dictator, but as a partner. So if you find yourself getting into that where you're too doctor centered, just realize that this is an issue and you have to think about how you involve your patient. Another one would be if you're using technical language and you're going to exclude your patient in the conversation. Okay. The next one is an over-explainer. So the over-explainer, what they tend to do is talk too much. In data gathering, they will say a lot of things about what the patient mentioned and summarize and clarify, going around in circle. Also in the summary tend to be the whole story. And remember, you don't get marks to summarize. You're actually wasting time that you could use in the clinical management. So if you have a tendency to talk a lot in the data gathering, or if you want to explain in an effort to show the examiner what you know, or you want to make sure that the patient understands, you might be losing your patient because you're overloading them with too much information. In the exam, they don't really want somebody who overload a patient with information. What they want is somebody who adapt the explanation based on the person's need. And in fact, I've noticed some people who have a lot of knowledge, they struggle for the SCA because they over-explain, while some people who don't over-explain, they keep it simple, they tend to do well. Okay, so if you find that this is an issue in your consultation, maybe you have to keep the explanation concise and adapted to that person.
If right now you're feeling overwhelmed about the SCA preparation, I've got a free gift for you. This is the SCA course that you can access. Just click the link down in the description, completely free. You can get the blueprint that hundreds of GP trainees have used to pass the SCA exam. This blueprint will help you to revise smarter instead of just working harder and practicing more cases.
The superhero, they try to do everything themselves. They have all the weight of the consultation, and for example, this is really relevant for long-term condition when it comes to diabetes. You're trying to do everything yourself, discuss a lifestyle, discuss a treatment, and the problem with that is that you don't have enough time to do everything yourself. So what you need to do is you need to use your multidisciplinary team. So for example, the practice nurse, the physiotherapist, dietitian, there's other members of the team who have got good expertise and they might be better person to discuss, let's say, if patient needs to have some advice about the diet, or if the diabetes nurse could do a review. So they could do some part of the lifestyle support. And then what you do would be to focus on the more high impact tasks that your GP would do. So you have to use your time wisely and delegate. Don't try and do everything yourself. Okay. Then the last one is a perfection trap. So sometimes you might feel like you want to make sure that you're doing everything right, and sometimes you get to that overthinking and you get paralyzed because you want to make sure that you're sounding really good. And the problem with that is you might then appear to be um, thinking, and then you pose and you show you're hesitant. So you know what, like there's no perfect consultation, so everybody will make mistake. It's human nature to make mistake. But what you have to do is try and make these mistakes before the exam and learn from them so that you don't repeat the same mistakes. And then in the exam, if you do make few mistakes, as long as it's not something major, carry on with it, and don't allow previous mistakes to affect your next consultation. Because if a consultation doesn't go well, then there's not much you can do about it. You have to look forward to the next one, and you should not allow what you maybe have missed or what the patient said before affect the next one. Okay, so keep a actual reset where when you have your 3 minutes reading time, try and do the housekeeping, forget about the last case, and focus on the next one. Is this clear so far? Okay, right. So next thing we'll be discussing is about breaking bad news. So when it comes to breaking bad news, in the exam, you might feel stress, and you get the results and you might feel like, okay, how am I going to break this bad news? Or but it's very different to real life, because you're breaking bad news over the phone or video consultation, and that's not the best setting to break bad news. But you still have to show that you've got good skill to break bad news. Okay. And what you need to be thinking is, what's your process of doing it? And this is where you need to understand that when you break bad news, there will be fears that the patient might have. And if you just focus on the medical, you're going to miss a lot of it. For example, if we take the example of the dictator, if you don't actually show consideration for what the person is thinking, their worries, or what's important to them, you might miss a big part of it. So if you push the agenda of what we're going to do next, referral and management, but then you didn't address the other issues, then you're going to lose mark. So if you tell a patient that they have cancer, for example, they might start to worry about, what if I die like my mom? Maybe their mom died of cancer 2 years ago. They might worry about, how am I going to tell this to my children? Let's say they plan a trip to Disneyland next week. So these are big concern for the patient, and you have to explore that. So when you break bad news, don't just rush into going to managing it afterwards. You have to try and be curious, find out what's going on in their mind once you've told them about the problem. So there'll be emerging concern once you break the bad news. And also think about from a patient's perspective, if you're just telling them medical jargons and all these uh, technical terms, it might be very terrifying for them. So you have to be careful about what language you're using. And also, they might feel completely alone in that when you're discussing it. So you should be able to talk in a tone of voice that you show that warmth, that you care about them, and that way they will feel that you're more approachable. So there is a challenge to do that over video consultation because there's a gap. It's not like you're in the same room, but there's still things you can do to work on that in the way of the way you sound, the tone, and also how you show you're listening, give them space and to process information. Okay. And at the end of the station, the patient should feel like they have a plan. And if you have given them a plan, they might still feel they don't have a plan, not because you haven't told them, but maybe because they have been so overwhelmed and they can't understand at this point because you've rushed it, or they were not ready for the information, or you've given them too much information. So, or if, for example, they're worried about how they're going to tell this to their children, and that's not been addressed, but you're telling them what's going to happen next, so they can't listen to you. Does this make sense? So that's where you have to understand what's going on in their mind, their concern, get on the same page. And then once you've understood that, then you can explain about what you're going to do afterwards. So who have heard of the spikes and uses it? Do you use spike? The first one is a setting. So if you're breaking bad news over the phone or over video consultation, you should show that it's not the best mode of consultation. So check whether the patient would like to come in person to go over the results. It's a courtesy to do that. And in the exam, they would tell you, no, I just want to go over the results now, doctor. So then check whether it's a good time for them, because sometimes it could be they could be um, at work at the moment. So make sure that it's in private setting. Then what you need to do is get the perception, understand what do they know about the results or the investigation they've had. So what I would ask them typically would be, may I check what did my colleague tell you about the tests, or can you tell me what led to the result, what led to the investigations, so that I get a bit of context and might say, yeah, I've been having this cough, and the doctor told me that I need to have an X-ray, for example. So now you understand what's been going on, and then you want to invite them to go over the results. So send like ask them, I've got the results with me, so would you like to go over it? So they might say, yes, yes, doctor, tell me. So then don't try and go into the history and ask more questions. Just tell them the results. And before you tell them the results, give them a warning shot. Okay. So you might say something like, um, this is not the results we were hoping for. It showed that there is signs of lung cancer, for example. Okay. And then this is where a lot of people struggle because they think that they have to give a lot of knowledge, but actually it's really adapted to what the patient needs. The patient might not want to know so much about the cancer and what to do. They might be worried, and we don't know how they can react. So every patient will react differently. So we need to understand the emotion. So how do you show that you understand that? It would be like, I can see this has come as a shock to you, and it is quite difficult, but I'm here to help you. So please let me know if you've got any concern at this point. So then they might tell you what other worries. All right. So what you want to do is try and elicit the concern once you tell them the results. And After you've done that, then they may be ready to listen to what's the next step. And then you can make a plan about referral, 2-week wait, investigations, what to expect, Macmillan Cancer Support, and then let them know whether if they can't attend an appointment or there's other things. Because usually in exam there will be a twist. They might tell you, yeah, but I can't actually attend an appointment because I'm going away this afternoon or something. Then you have to start negotiating. So once you've done that, then make sure that you leave the patient with a plan. So in breaking bad news, it's a good idea to outline your strategy and summarize at the end so that you make a clear plan as in what's going to happen so the patient doesn't feel lost. Okay, so you could say and the ending is really important, how you end it. You could say to the patient, I appreciate this is not what you were expecting today, but it's a good thing that we found out what's the cause of this cough, and I'm going to make sure that you're seen by the specialists, the respiratory physician, so that they'll be able to investigate further and decide what's the best treatment for you, something like that. So at least they have a clear plan what's going to happen, because they might forget or something. And also, as you're discussing the plan, make sure you check whether they've got any questions or anything. So that's the process of going through it. And don't rush. You might feel like you need to rush, but if you rush it, then you're not going to do a good job. Any questions so far? Okay.
Yes, I have a question.
Yeah.
From exam point of view, if it's a cancer, they are interested that we ask about smoking, family history of lung cancer, if patient have lung cancer, for those red flags, they are still taking 30 cigarettes per day. Now, the problem is when we give the results and it's breaking bad news, they're already crying, and then they're more interested to know what our next step rather than we go back and ask these things and address where we stand. Should we leave it, or if no, what is best way to address this?
Yeah, good question, Asim. So if you can see on the record they smoke or something related, they have risk factors, and you feel like you can address it in this consultation, you may do so. Okay, but if you feel it's really difficult to address this today, then you don't have to address it today. But you could arrange a follow up and say we can have a chat next, maybe in a week time, discuss what are the things that you can do as well, if you'd like. So you have to gauge it based on how the patient react, whether it would be a good time to do it today, or if you've already feel like they are quite overwhelmed, maybe it's not a good thing to do today. In terms of red flags, if you already know they have cancer and the results is showing that, there's not much point in asking about these red flags because we already know that they have cancer now. So it's less relevant. Okay. Is this clear?
Yeah.
Yeah.
So, if the patient said that, how can I tell my children? So here, so that how can we approach this?
So then you have to be more curious and ask, like, how old are your children? Do you think you can have a chat with your partner first?
Okay.
Okay. Yeah. Next.
Dr. Kwun, thanks a lot for today. So I think just like you mentioned, not being rushy, especially in these settings, will it be a problem if by the end of the day, when you're trying to take your pace with the patient, you're not able to tidy up, but maybe you see just maybe a minute left, then you say, are you happy with fixing another appointment to discuss further, maybe with a family member? Does that sound safe?
Yeah, so if you realize there's not enough time, it would be sensible to do that. You can even say, I'm aware that we've got limited time today, but I'd like to go over it with you, and if you got any questions, would it be helpful if I book you a double appointment tomorrow?
Okay.
Something like that. Okay.
All right. Thanks.
Yeah, Alvina, yeah, you got a question?
Yeah, just following what Asim said about the case like lung cancer and in which smoking and those things were important. And you mentioned that if there is in the history that he is a smoker or anything like that, but if nothing is mentioned there, so still we don't need to ask about all these things.
So it depends how the case is. Obviously, yeah, smoking is a risk factor, and it is something that you might want to address, but you have to gauge whether you feel like it would be a good time to ask it at this point. I mean, if you know, for example, you're going to discuss about lung cancer, before you tell them that they have lung cancer, you feel you want to ask that question, you could. Because you could say, I just want to check whether there could be any thing related that could affect your lungs. So can I check, do you smoke? And then if you get that, then you can explain in the management that I think based on the results and what you've said, you have some risk, and it is important to consider if you would like to cut it down, because that might help in the future, something like that. But you have to be careful how you do it. You can do it. It's how you do it that makes a big difference, whether you do it smoothly or if you're doing it in a way that you're telling off the patient.
Thank you.
Okay. Right. Any other questions? Okay, so thanks for the questions. So the next thing is, I want to recap on the attitude, because when you're sitting an exam, if you're very stressed, you might forget, or you just go back to your default mode. But make sure you stay curious. You know, when you're curious, you're going to ask more pertinent questions, and you're not just going to be focused on the medical, but you want to know a bit more about what's going on in your patient's life. And the second one is being kind and show that kindness. If you show that kindness, the patient can feel it. Like when you speak with somebody, they can tell whether you're genuinely caring or you're just saying it because you know that you have to say that for your exam. And it feels very different when it lands on the receiving end. And then I'm sure you have that experience as well when, for example, you go somewhere and you see somebody is very kind, but then maybe they're doing it because they've been told to do it, for example. Okay. And the last one is being positive. So, you know, when you consult, you bring your energy, and you have to be careful, as in, don't bring that negative energy if you're anxious, nervous, because that's going to affect the atmosphere of the consultation. And the patient might feel even more anxious if you're bringing that energy. Okay. So just be careful about what energy you bring in, and stay positive, and a can-do attitude is really helpful for the exam. Okay. Um, the next one is a skill set. So the skill set, you already have developed various skill set, as in how to interpret results, how to discuss it to the patient, and when you use a framework, it's going to actually show that you're doing it well, the skills, and in achieving that good outcome for the patient. So some of you might be familiar with this framework, but you need to have a framework when it comes to discussion of results. Otherwise, you might not approach it well, and then you'll have problems with your time management, or you might find that you're rushing at the end. So just to make sure that you're clear about this, in the first 3 minutes, you have to be finding out a bit more about the patient to get the context, the perception, and then try and deliver the results within 3 minutes. Don't leave it too late, because once you deliver the results, there will be new things coming up, and you don't want to wait at 6 minutes to do that. Okay. Show empathy, explore more about what's their concern. if you feel it's necessary or it's the good time to ask, you can even ask about the psychosocial, anything that could be relevant. Okay. And then once you've done that, then you go into the management. So a common mistake I've seen is people just jump this part and they go straight from here to discussion of the plan. And you're missing the whole eyes in the psychosocial. And that's where you can really fail a station like that. Okay. Right. So we've talked about the attitude, the skill. Now we're going to talk about the behavior. So when it comes to behavior, there are two set of behavior. There's a verbal behavior, and verbal behavior is what you're saying to the patient and how you say it. You might say the exact same word to a patient, but one candidate might pass and one candidate might fail because of the way you say it. And also the non-verbal as well, like your facial expression and how you communicate, whether your body language showing like you have this nervous tick or fidgeting, touching your face. These are going to send cues to the patient that maybe you don't know what you're doing. So then they might not trust you. So you have to be careful about the verbal and the non-verbal behavior. And the patient also, they will give you cues as well. So you have to pick up on that. So let's say an example of an incongruent behavior, it could be like, yeah, I understand this must be hard. So do you feel like this is congruent? It's very easy to pick up. It's not congruent. Like if I say to people, yeah, I understand this must be hard. It sounds a little bit dismissive and it's not matching to the words. So you have to be careful that this is something that you might do under stress, or if you're feeling rush, you see like the time is ticking. But the best thing is don't rush in breaking bad news, because the patient will feel a bit dismissed. Instead, what you want to do is take your time and say, yeah, I understand this must be hard, Sarah. Use their name as well if possible. Feel more personalized. Okay. And otherwise the patient will feel like, yeah, you say something but it doesn't look like you care. And then the patient needs to feel like they're not going to be left on their own, so show them that there is a path and there are some things that we can do to help them. Okay. And do it in a congruent behavior. Okay, so why this matters is because incongruent behavior, it erodes trust. You're going to create more anxiety. The patient will feel like they're being dismissed, and then there's also poor understanding of what you're saying, because you say something but then you don't mean it. Whereas if you're congruent, you're going to build trust. You're going to help the patient stay calm despite the difficult news. They will feel like they were seen and heard, and also the understanding will be easier because what you say and how you're saying it matches. Okay. Any questions so far? No? Okay. Right. So the next thing we'll do, we'll go over a case, and this is going to be about investigational results, and there will be also prescribing involved in this. So let's prime this case together. Imagine you're in the exam and you've got this case. So have a look at it, read it, and then think about what you're going to do. Have you finished reading this page? Let me know. Yeah. And then we'll move on to the next one. Okay, so this is the results. The standard is quite high, you know. In the data gathering, you have to use information, and I think you've used that well, and you recognize the abnormal finding. I don't think you did specifically ask about the neurological signs in the beginning. You just asked, do you have any symptoms? It's too vague. And in this case, it is quite important to know whether they have neurological symptoms rather than just doing it in the safety netting, because that would change the urgency of the management. All right. For example, if this patient did have neurological symptoms, you would not just offer oral tablets. Okay. Then in terms of things that you need to consider would be like other psychosocial impact. I think that's where you miss it, and then you realize you should be asking more about how is it affecting you, and then you went back to do that. So yeah, remember there are free buckets, and don't, once you deliver the results, you can still do the data gathering. You don't have to do the management straight away. Okay. Um, So in the clinical management, you did add the intrinsic factor you were considering to do that. You would typically consider offering like injection. So if you knew how you do the injection, you would say like through the muscle and then 3 times a week for 2 weeks. And then you did mention about the other aspect of food as well. Now, if this patient had um, vitamin B12 deficiency, um, but let's say they didn't have anemia, probably like, yeah, like if you give them like a tablet, that would be fine, or explain about the food as well, that would be fine. But if it's affecting her that much, I think injection would be sensible in that instance, or if they do have neurological symptoms. Then in terms of the follow-up, you would consider reviewing, which was fine. I think you did that. In terms of the treatment plan and an explanation was clear. I think the eyes here was not very clear, because then the patient kind of asks you afterwards, remember? So you have to be more clear and check whether they understand. And here it was clear that the patient is vegan, so it was a quite straightforward reason. In the relating to others, so the examiners are looking whether you're exploring the eyes, what the patient is looking for, and thinking of the psychosocial, and how you do the shared decision making. Whereas if you just decide, it's not as good, you see. Then in terms of other things, I don't think you use any jargons, and you did eventually recognize the impact of the tiredness, and how is the patient feeling about it's affecting them quite a lot. But I think it could be more smooth, you see. So yeah, I think it's good that you did that practice, because now you have learned it and it will stick. Because you see, like we've just gone through this beforehand, and you still need to practice and refine it. Because just learning from a video or reading something is not enough to close a learning loop. To get better, so important that you go through this learning cycle. And what I want to bring to your attention is, some of you here might be learning at a very different speed, and the one that do well for the exam, their learning velocity is much higher than those who tend to don't do that well. What I mean by that is, let's say I consult a case today, I do a review of the recording, I get feedback, I adjust, I implement, and put that in practice next day. And somebody else who is doing that maybe in 1 week, they are doing, let's say, 3 cases, but every day I'm doing 2 cases. By the end of the week, that person who is doing 2 cases every day, they are moving at 7 times 2, so 14 cases going through this cycle, whereas somebody who's doing, let's say, just 3 cases in a week, they are just free cycle. So 3 compared to 14 is a big difference in 1 week. So it's very important that you understand what's your learning cycle like and the velocity. Because if you're moving at, let's say, speed of 3 in a week, somebody else is moving at 14 in a week, it's no surprise that the person who's going through 14 in a week, they're going to get much higher results. Okay. And the nuance here is don't just practice, you have to go through the cycle. You review your recording, get feedback, adjust, and now you know what are the things to look out for. We've talked about the five horsemen. Try and find out these patterns in your consultation. Okay. Right. Any questions? Any other questions?
Yeah, yes, please.
Yeah.
Thanks a lot, Asim, for stepping up. If I may just ask, will it be not good if, because I already have here on record, patients 2 weeks ago had a telephone. So is it wrong to just come in, hi, I'm this, and you explore their name? How can I help? And they say, oh, they came in for a result. Is it wrong for me to say, oh yeah, I see you had a telephone review with my colleague, Dr. Jones, 2 weeks ago. Is that still the same person? And he says yes. Is that wrong? Because you're trying to make it, because everything is actually given to you, rather than asking her, why were you giving why did you, I'm just asking what you
it's
think.
actually more informed of you if you do that. If you tell them, I've had a look at the record, I see that you've had tiredness and had some blood tests. Is that what you're here to talk about today? So that's a smooth way of actually starting the consultation.
Okay, so it's okay with that.
So it would not be bad. It will actually be good because then you show you're using the information provided.
Using the information provided. Okay. Okay, sounds good. Okay. Just to regarding, I know she's vegan and it's something to point out from there. Would it be good to just talk about if she's open for you to make some dietitian referral just for any further advice, or I'm just, would it be an
that would be a good
inappropriate?
point.
Okay,
So
so
if you feel
dietitian.
like this patient would benefit from it, you can do it. If you feel like that would be appropriate, if you feel you want to signpost them to the information, so yeah, you could do that as well. The dietitian would be a good suggestion.
Okay, and then finally, you keep talking about gift wrapping.
Yes.
So patient clearly says her work is not stressful. So it seems as though it's not really impacting on her work, but it's the home, isn't it?
Yeah.
So can you please gift wrap this management? So, just to bring it in smoothly.
So yeah. If you gift wrap this management, for those who don't know about the gift wrapping concept, is G is to gather insight, I is to individualize a plan, F is how you frame it. You have to frame it in a person-centered way based on their circumstance. And then T is you tailor the management plan based on the patient you've got.
If you found this video useful, you might want to watch this video in which I go more depth on clinical management. Click the video to watch it. Take care, everybody. Bye-bye.